USMLE style question A. A 23-year-old male collapses while playing basketball. His teammates report that he briefly lost consciousness but regained awareness within a minute. He has had occasional episodes of dizziness and exertional dyspnea over the past year, but never sought medical attention. His father died suddenly at age 45. On examination, BP 110 70 mm Grav, HR 78 BPM. Cardiac exam, harsh, crescendo decrescendo systolic murmur at the left lower sternal border, which increases with Valsalva and standing and decreases with squatting. ECG shows left ventricular hypertrophy and deep T-wave inversions in the lateral leads. Which of the following is the best next step in management? A. Reassurance and lifestyle modification. B. Exercise stress testing. C. Implantable cardioverter defibrillator ICD placement. D. Coronary angiography. E. High-dose beta blocker therapy. Answer and explanation. C. Implantable cardioverter defibrillator ICD placement. This patient has hypertrophic obstructive cardiomyopathy, HOCM, with a history of syncope during exertion, a strong predictor of sudden cardiac death, SCD. Given his high-risk status, the most appropriate next step is ICD placement for primary prevention of ventricular arrhythmias. Why ICD? ICD is indicated in HOCM patients with high-risk features for SCD, including history of syncope, especially exertional, family history of sudden cardiac death, massive LV hypertrophy, 30 millimeters on echo, non-sustained ventricular tachycardia NSVT on Holter monitor, hypotensive response to exercise. Management approach for HOCM, beta blockers, e.g. metoprolol, first line for symptomatic patients, ICD indicated for patients with high risk for SCD, avoid high-intensity sports and dehydration, septal reduction therapy, surgical myectomy or alcohol ablation for severe cases. Why not the other options? A. Reassurance and lifestyle modification. Lifestyle changes, avoiding strenuous exercise, help but are not enough in a high-risk patient with exertional syncope. B. Exercise stress testing. Not safe in high-risk HOCM, could provoke life-threatening arrhythmia. D. Coronary angiography. Not necessary unless angina suggests ischemic heart disease. E. High-dose beta blocker therapy, used for symptom control but does not prevent sudden cardiac death in high-risk patients like this one. Key learning points for HOCM and syncope. Exertional syncope equals red flag. Think ventricular arrhythmias and LV obstruction. ICD placement is life-saving in high-risk patients. Beta blockers help with symptoms but do not reduce SCD risk alone.